Think of pneumonia as an infection that primarily affects the tiny air sacs in your lungs. These are called alveoli. Normally, these air sacs help you exchange oxygen and carbon dioxide. But when you have pneumonia, they can fill up with fluid or pus. This makes it harder to breathe and can cause symptoms like cough, fever, and chest discomfort. When we classify pneumonia, we usually think about it in a few different categories. First, there is community acquired pneumonia, which is the kind of pneumonia people get in their everyday environments, like at home, school, and out in the community. Then there's hospital acquired pneumonia, which occurs 48 hours or more after someone has been admitted to a hospital. It tends to involve different bacteria and can sometimes be a bit more challenging to treat. There's also ventilator associated pneumonia, VAP, which happens in people who are on mechanical ventilation. So, when we're talking about the clinical presentation of pneumonia, here's what we typically see. Patients often have a fever, a persistent cough, and they might experience shortness of breath. They can also have sharp chest pain that gets worse when they breathe deeply or cough, and generally feel fatigued, unwell, and may lose their appetite. In elderly patients, we might see confusion as well. Clinically, we might notice fast breathing, crackles or bronchial breath sounds, and a drop in oxygen levels. In severe cases, there can be sepsis. Lab findings often show a high white blood cell count and elevated inflammatory markers like CRP, ferritin, and procalcitonin. And that's the clinical picture. We might also do a chest x ray, which can show infiltrates or areas of consolidation in the lungs. When it comes to treating bacterial pneumonia, antibiotics are the mainstay. The specific choice of antibiotic can depend on the patient's overall health, any other medical conditions they might have, and the likely bacteria involved. For healthy patients with mild CAP, if the patient is otherwise healthy, has no other illnesses, and a low severity score, like CURB 65 of 0, you can use a high dose of amoxicillin or doxycycline. If local resistance patterns allow, a macrolide like azithromycin can be an option. For patients with comorbidities, if the patient has other health issues, combine amoxicillin clobulinate with a macrolide or use an oral cephalosporin plus a macrolide. If they can't tolerate these, a respiratory fluoroquinolone like levofloxacin can be used alone. For hospitalized CAP, if the patient is in the hospital but the pneumonia is not severe, use ceftriaxone plus azithromycin or respiratory fluoroquinolone. For severe cases, combine an antipneumococcal metolactam with a macrolide or fluoroquinolone. Special considerations. Add anti-pseudomonal coverage if the patient is at risk for pseudomonas, and consider anti-MRS agents if MRSA is a concern. In essence, for pneumonia, you typically treat with antibiotics for at least 5 days. The key is to continue until the patient has been stable, no fever, and breathing well for at least 48 hours. In straightforward cases, 5 to 7 days is usually enough. If there are complications or resistant bacteria, the course might be longer. So, in the case of hospital-acquired pneumonia, often called HAP, it's basically any pneumonia that shows up at least 48 hours after a patient has been admitted to the hospital. That means they didn't have it when they first came in. For treating HAP, we typically start with antibiotics that cover tough hospital germs. That includes an anti-pseudomonal beta-lactam, like piperacillin tazobactam, cefepime, or meropenem. These are chosen because they cover a broad range of hospital bacteria, including Pseudomonas.